Hello and welcome to this case study where we will discuss some tips on the management of stage 3 non-small cell lung cancer. I will discuss the case of Mr. Muhammad. He is a 59 years old gentleman who works as a driver and he's a heavy smoker since 40 years. He has controlled hypertension and negative other medical history. He has no family history of cancer and he has a history of prolonged cough and expectoration in the past 2 months. He sought medical advice with a chest consultant and he prescribed some supportive treatment that he didn't improve on. So he requested a CT scan which showed a suspicious 7 centimeters right lung mass and mediastinal lymph nodes. This is a CT scan of Mr. Muhammad, and as you can see, there is a suspicious mass in the right lung, and in addition, you have also hilar and mediastinal lymphadenopathy. This is a picture of an aplastic process, and the CT scan was suspicious, so he went for a CT guided biopsy that showed a poorly differentiated adenocarcinoma for immunophenotyping. That's a very common report that we get, and but the immunohistochemistry here is requested to differentiate primary from secondary cancer. So, what to do in that situation? My first tip is that please make sure that you have enough tissue to go for the full panel of immunohistochemistry because sometimes the tissue from the CT guided biopsy is not enough to go for the full panel of immunohistochemistry, followed by the genomic testing having proved to be of primary lung cancer. So, if that gentleman, the heavy smoker, who have a typical picture of primary lung cancer and who might be even positive on the bronchoscope and nowhere else in the body you have evidence of another primary tumor, there is a very low possibility that this gentleman is having a secondary cancer in the lung. So we did the very essential immunohistochemical panel where we have the TTF1 positive, and for most patients we can consider this as an evidence to have a primary lung cancer. In addition, the patient had a PDL1 positive disease. We did a PET scan to stage if he has a distant metastasis or not, and we found no distant metastasis, but we confirmed the FDG activity of the lung mass and the mediastinal lymph nodes. So the first question that Mr. Muhammad wanted to discuss is how bad is his cancer is? What's the stage of his cancer? That's a very important point to discuss because each new patient with cancer, despite that you can think that he knows everything about his disease, he needs to discuss the specific prognosis of his condition. So if you look at the lung cancer staging system, you can see that he has a clinically T3 tumor and N2 disease as he has a mediastinal lymph node. And hence he would have a stage 3B disease. My second answer to Mr. Muhammad was really sad. His question needed to know about his prognosis. And in general, when we're talking about cancer and we think of a non-metastatic disease, you might think the prognosis is really good. However, stage 3 lung cancer carries very trivial prognosis. If you can see, the 5-year survival is less than 19% if stage 3A and around 7% if stage 3B, like Mr. Muhammad. So this denotes to you how bad really stage 3 lung cancer is. And again, that's despite the advances that have been through in the past 20 years. The second question that was asked by Mr. Muhammad is, can I have stage 3 lung cancer at the first day of my diagnosis? Well, uh, just hearing it's stage 3, meaning that he should have passed through stage 1 and 2. And this is a very logic question by the patients because they think that while I'm discovering the disease now, it should be a stage 1. Yet, we should make clear to our patient that the stages are related to the site of the disease and the size of the tumor, but it doesn't necessarily means that he should have his first complaint when he has stage 1 disease, simply because lung cancer is usually non-symptomatic in stage 1 or even early stage 2 disease. So that's why 22% of patients are diagnosed with a regional disease just like our patients. And in addition, more than 50% of the patients are diagnosed in metastatic disease. So how are we going to treat Mr. Muhammad, who is a case of stage 3 non-small cell lung cancer adenocarcinoma? Well, first we've discussed in the MDT, and again, as he had bulky mediastinal lymph nodes, he was considered inoperable, and hence he was offered to receive chemotherapy and radiation at our clinical oncology department. And if you just check the NCCN guidelines for that scenario, you will see for stage 3 non-small cell lung cancer, you would have almost only one option, which is definitive concurrent chemoradiation. So here the question is which chemotherapy to use, which radiation therapy to use, and how to sequence those regimens. So the first step, in my opinion, every single patient with lung cancer is to advise him to stop smoking. Several studies have shown that patients who were diagnosed with lung cancer and were smokers at diagnosis and who stopped to smoke after being diagnosed, they had better survival, as you can see in that curve, compared to those who kept smoking after diagnosis. This difference is almost more significant and more pronounced than you can achieve with any treatment that you add to your patient. So the question is, why concurrent chemoradiation? Where did that come from? If we're going to use chemotherapy and radiation, you can use them in sequence or you can use them concomitantly. Several studies have compared concomitant versus sequential use of chemoradiation. And this meta-analysis have combined the results of all those studies, and you can see that using concurrent chemoradiation have resulted in around 16% lower risk of death compared to sequential chemoradiation. And if you look at this survival curve, you can see that the yellow line with concurrent chemoradiation have an absolute benefit of around 5% compared to the sequential regimen. This means that you can save around 5 patients from each 100 patients only by choosing the right timing of chemoradiation. Please also note how bad those survival curves look. So there are 10 to 15% of patients only who are surviving up to 5 years. However, this benefit of concurrent chemoradiation compared to sequential chemoradiation comes at a cost of increased side effects, the most important of which is the acute grade 3 or more esophagitis. And grade 3 or more esophagitis is really a serious condition. This patient is going to be admitted in the hospital and to be fed through IV fluids. In addition, there is increased in the pneumonitis risk, and this risk is with addition of chemotherapy in general and not specifically with the sequential with the concurrent chemoradiation. So it occurs with both sequential and concurrent radiation therapy. So while efficacy is increased with the concurrent regimen, however, the toxicity is also significantly increased. Now that we have answered the question of the timing of the treatment, we should answer which chemotherapy to use and which radiation therapy to use. So, which chemotherapy? A broad idea is to use a platinum-based doublet, where you have a platinum agent, cisplatin or carboplatin, and you have another added agent, whether etoposide, vinblastine, pemetrexed, and paclitaxel. You can use either of them in addition to each other, but please note that the doses used concurrent with radiation are smaller than those that are used in the metastatic setting or in the adjuvant setting. Also, you have another option in high-risk patients, where frail patients, older age, those who you can think will not tolerate the increased toxicity of concurrent chemoradiation. You could give sequential chemoradiation, you could give single-agent cisplatin chemoradiation, not the doublet, and you could even give radiation therapy alone in elderly and frail patients. Next question is which radiation therapy protocol you use. And the radiation therapy protocol should be described in terms of the dose of radiation, the fractionation schedule, the adjustment to treatment, and others. First adjustment point that we advise to use is to account for respiratory motion. There are different systems that you can use, and we prefer, if the patient can tolerate that, the deep inspiration breath hold. If the patient can hold his breath, and that's not a very easy thing in lung cancer patients, that would help a lot to decrease the volume of the radiation to be included and to help to stabilize your patient during the radiation therapy session. What about the fractionation schedule? Here we have a very famous trial, the CHART trial, that compared patients with non-small cell lung cancer candidate for radical radiation therapy with two fractionation schedule. The first one, the 60 grays in 30 fractions over 6 weeks, that's the regular regimen that we use in most patients nowadays. The other regimen is a very peculiar regimen where you do use what we call accelerated hyperfractionation. You're using 54 grays into a 36 fractions, that's more fractions, but giving it in only 12 days. This means that you give 3 fractions of radiation therapy each day. And this is only possible if the patient can tolerate that and the radiation therapy department can accommodate such difficult schedule. The chart resulted in improved 2-year overall survival from 20% to 29%. That's very significant. And please note that that was before using concurrent chemoradiation. So that study compared only radiation therapy regimens. In addition, a large meta-analysis that pooled the data of different studies that compared the accelerated fractionation versus the normal fractionation, and it showed very similar result to the CHART trial. Accelerated hyperfractionation can improve the survival. But again, can we combine this with chemotherapy? There is very little evidence to suggest that, which means that accelerated fractionation could be an option for those who would not be able to receive chemotherapy. For example, if they have renal failure or other comorbidities that prohibit the use of chemotherapy. In such situation, you might use accelerated hyperfractionation and to improve over the regular fractionation schedule. But if you're using concurrent chemoradiation, most of us use the regular 60 gray in 30 fractions. But can we increase the dose of radiation therapy? That's a very important question. Why are we stick to the 60 grays? Why not to increase the dose? That might improve the outcome. And the RTOG 0617 study asked that question in patients with stage 3 non-small cell lung cancer. 464 patients were randomized to receive the regular dose plus paclitaxel and carboplatin versus to receive the higher dose, the 74 grays plus the same chemotherapy regimen. Please note that some patients were randomized to receive cetuximab or not. Results of the RTOG 0617 were striking. If you look at this survival curve in front of you, the overall survival is better in the red arm, and the red curve is the low dose. The 74 grays, the dose escalation, resulted in poorer survival compared to the lower dose. In addition, even the local tumor control, the local failure was more in the high dose. And that's very surprising. How does a high dose of radiation therapy result in lower local disease control? Well, that might be due to the more grade 3 esophagitis, which might interfere with completion of the radiation therapy and chemotherapy course adequately. This means that for our patients today, we need to stick to the 60 to 66 grays doses of radiation therapy and not to escalate beyond this. This is the NCCN guidelines for the radiation therapy technique, and you can see that you should use doses 60 to 70 grays, not to escalate above that, and you have to use the involved nodal field, the involved field of lymph nodes, and you do not use the elective nodal where you can irradiate in non-involved lymph nodes. So we irradiate only the positive lymph nodes and we irradiate the gross disease from 60 to 66 grays. So those are my advices on what you shouldn't do when doing concurrent chemoradiation for stage 3 lung cancer. First thing, you do not escalate the dose as we mentioned before from the RTOG 0617 trial. In addition, you remember the cetuximab comparison between radiation chemotherapy plus or minus cetuximab. Again, it was negative, so you shouldn't add cetuximab to concurrent chemoradiation. The third, you should not use extended fields of radiation therapy. You should limit your radiation therapy to the involved nodes and the gross disease of the tumor only. You can use some IMRT or techniques that reduce the dose to the normal structures. And finally, you do not use maintenance chemotherapy after radiation. So if you give concurrent chemoradiation and you think that you might add more chemotherapy, for example, docetaxel, which is used in the second line treatment of lung cancer. Again, the Hoosier phase 3 oncology group study compared this comparison and failed to show superiority of the addition of maintenance docetaxel. So we do not use maintenance chemotherapy with docetaxel following concurrent chemoradiation. So what to do after we finish successful chemoradiation for those patients? Please remember that we have a generally very poor 5-year survival in those populations because most of them, they have progression or relapse within the lungs or within distant sites. Here we should look into the idea of immunotherapy, where we have what is called immune checkpoints, where it is designed to stop the immune system, the immune cells like T lymphocytes, from being activated, from attacking the other cells that might be suspicious, like the cancer cells. But these off switches or the immune checkpoints prevent us from having autoimmune disorders. But during the evolving of cancer, some cancer cells, they have what we call the inhibitor of the immune system. They have the ligand that inhibits this immune checkpoint, which is the PDL1. So if you develop an antibody against this PDL1, you can stop the off switch of the immune system and hence stimulate the immune system to attack the cancer cells. In theory, if you combine the chemoradiation with immunotherapy, you might result in a theoretical synergism. Why is that? Because chemoradiation will kill many cancer cells in the very short time, so it will release many of the tumor antigens into the circulation to be uptaken and recognized by the immune system. Here, if the immune system is inhibited by the PDL1 that switches off the T lymphocytes, and you add the anti-PDL1 antibody, for example, like durvalumab, you can turn off that off switch, meaning you turn on the immune system and initiates anti-tumor immune response cycle that is synergistic with the chemoradiation. So to put this theory into testing, the Pacific study was designed and was conducted. The Pacific study is a phase 3 randomized placebo-controlled trial that included patients with unresectable stage 3 non-small cell lung cancer, just like Mr. Muhammad, our patient, after finishing the concurrent chemoradiation and to have received at least 2 cycles to full cycles of chemotherapy. Patients were included irrespective of their PDL1 status, and they were randomized within a window of 42 days only to one of two arms, whether durvalumab by dose of 10 milligram per kg every 2 weeks for a total of 1 year. This maintenance therapy of durvalumab was compared to same maintenance schedule of placebo, and patients were followed up with the primary endpoints of progression-free survival and overall survival. Happened in the results of the Pacific study. If you look in front of you, this progression-free survival curve is very impressive. You can have a median progression-free survival of around 17 months with durvalumab versus only 5.6 months with placebo. Again, please note how the outcome of the placebo arm is really modest if you compare that to any stage 3 cancers elsewhere. At 5 years of follow-up, you can notice that there is significant improvement of the progression-free survival rate from 19% compared to 33% with the addition of durvalumab. Please also note that the placebo arm here did not do very bad or worse than expected. Well, 19% is much better than the numbers I've shown you in the beginning of this video. Also very impressive is the overall survival results of this study. In the Pacific study, the median overall survival was 47.5 months in the durvalumab arm compared to only 29 months in the placebo arm. And if you think this is a bad prognosis, please remember what I showed you in the first slides of the video, where you can see that even the placebo arm in this study did much better than expected from stage 3 non-small cell lung cancer patients. And if you look at the 5-year results, this is really impressive, where you have around 43% of the patients in the durvalumab arm, they are still alive, compared to around 1/3 of them in the control arm with placebo. Finally, if you looked at the subgroup analysis, this slide showed that almost every subgroup of patients did derive similar benefits from the addition of durvalumab regarding the progression-free survival. And finally, the side effects profile of durvalumab. Please note that here we have some very relevant side effects that are significantly increased if you use durvalumab. Please remember that cough and pneumonitis were really a problem when using chemoradiation, whether sequential or concurrent. And this pneumonitis problem is even aggravated when you use durvalumab in addition to chemoradiation. Here, if the patient starts complaining of progressive cough and dyspnea, you should stop the treatment and you should look for the reason for this pneumonitis. It could be very severe and it could lead to severe and lethal complications. In addition, some few immune-related adverse events are also increased with the addition of durvalumab, but other than the pneumonitis, most other side effects are tolerable or are comparable with the chemoradiation. Please note that the chemoradiation is not a very innocent treatment. And finally, again, to our guidelines, if you look at the guidelines today, it will show that concurrent chemoradiation followed by maintenance durvalumab for 1 year should be the standard of care for patients with fit stage 3 non-small cell lung cancer who did not progress after chemoradiation. Thank you very much for watching. And if you think this video was useful for you, please check other videos on the channel. You will have several other lectures on other types of cancer and subjects related to clinical research. Thank you very much and see you.